a lot of antibiotics and steroids. We could do something with the fluid, give them I mean, dialysis and dry them out at one stage, and then evidence changed quite a lot of using less fluids. Antibiotics, we are all struggling with what to do. Steroids, again, almost everyone came to ICU and got steroids, and there was no way in which you can remove it or anything if there are major adverse effects. Is it beneficial? Is it not beneficial? Has always been a question, but there's enough evidence to tell that it is useful in certain places and not useful in certain places. So to start off, before we go into the whole thing about steroids, I'd just like to take a minute of good silence to the crisis going on. And Naveen, he's actually a fourth-year medical student who has died as one of the civilians from Karnataka. And if you can all keep silent for a minute or so, it'll be great. Okay, so let's move on. So, I mean, we all know that we'll go through a few of the circumstances in which steroids are thought about for during treatment of our patients in the ICU. And one of the most common ones we start looking is for acute bacterial meningitis. There's enough, it's always been suggested to give steroids before the antibiotics, and it reduces I mean, bacterial meningitis itself is such a high mortality, almost 1 in 10 die. And survivors, unfortunately, can have neurological damage. It is not uncommon, and I remember one incident where a 26-year-old girl, we were unable to extubate because she was unable to hear us call out her name and things, only to realize after extubation that or there was a delay in extubation, only to realize after extubation that this young girl who had bacterial meningitis did not get her steroids in the community as she reached the hospitals, got intubated, and had some hearing loss. It was temporary though, and the girl did recover with partial hearing recovery, but it is a major insult to the patient, which we can always prevent. So, I mean, we know it happens in bacterial meningitis. Steroids are very useful, but unfortunately, it does not work in every type of bacterial meningitis. Gram-negative meningitis, which is not uncommon in our own country, has not been evidenced to have beneficial effects by giving steroids. So, either in terms of mortality or in terms of, we always never looked at mortality, but we looked at a difference in neurological outcomes. And so generally, once we come to know it is gram-negative meningitis, we can stop the steroids. But there's always a caveat, because we wouldn't come to know how long I mean, before the reports of the CSF or any analysis actually comes back. So it may be almost 3 to 4 days when the treatment with the steroids has completed. So essentially, and the Cochrane report in the 2015 does mention about a reduction in mortality, mainly with the strep pneumonia meningitis, and not in any other type of gram-positive as well, or the Neisseria meningitis, which is gram-negative. In tuberculosis meningitis, there is evidence that, yeah, I mean, it is highly recommended. So the doses are given. Usually we start off with the 10 milligram 6 hourly and then give it for 4 days if it is strep pneumonia. And if we come to know earlier, we can always discontinue steroids. In TB meningitis, give a slightly higher dose up to 0.3 to 0.4 milligrams per kg, which will come to approximately around 16 to 18 milligrams uh, of dexamethasone. This is for the first 2 weeks, the same dose is given, and then it is tapered on a weekly basis. But a minimum of 8 weeks of steroids is given in tuberculosis meningitis. Traumatic brain injury, one of our, I do understand most of us don't practice giving steroids in traumatic brain injury anymore, but occasionally we do come across TBI, which has got steroids prescribed. There is, initially it was thought that steroids reduces the cerebral edema and hence it is of use, but the crash study in 2015 actually with a very large number, more than, I think it was 10,008 patients with moderate to severe traumatic brain injury got methylprednisolone, and they actually found a higher mortality in 2 weeks and as well as at the six-month follow-up in the methylprednisolone group, let alone all the other complications of infections and GI bleeds, etc. So the current Brain Trauma Foundation guidelines do not recommend use of any steroids, either for improving outcome or for reducing ICP. So it's never been a rescue therapy for ICP management, and should never be a treatment in that case. Again, the evidence is very straightforward here. Spinal cord injury, this very controversial topic in terms of spinal cord injury, the ability to give steroids and its outcomes. The National Acute Spinal Cord Injury Studies as early as 1990 was when the third one was published, and the previous two, the NASCIC 1 and 2 were in the mid 80s, where and there was some evidence of having minimal improvement in the motor score and functional outcome. What was the results of the study? However, when initial bolus, I mean, this is what is currently also used, initial bolus of 30 milligrams per kilogram over 15 minutes, and then 5.4 milligrams per kilogram for the next 23 hours. For a total of 24 hours, sorry about that. However, there's been a lot of challenging in which the way in which the study was done, because the way they looked at the control group, which did not have any motor deficit. Most of the patients in the control group, or a larger number of patients in the control group, did not have any motor deficit at presentation. This means that they cannot find a difference in improving of the motor deficit if the steroid is not given or given. Also, they did a reanalysis of their primary outcomes. It was only in the post-hoc analysis that they got some positive outcomes of having an improved motor deficit. And so these even guidelines like the NICE guidelines do not use steroids, even though this came out at the same time. Enormous risks of having infections and other complications based on steroid is what. So generally it is not recommended. However, the practice continues that if it is if there is a ability to give a patient within the first 8 hours of a spinal cord injury, and it must be an isolated spinal cord injury, then steroids may improve the outcomes. in terms of neurological deficit. But if it is not associated with any other type of traumatic brain injury, for the TBIs anyway, there's increased mortality. So use of steroids is completely contraindicated. So we should actually not be giving. So to take home, I would say that it's probably not necessary to give any steroids in spinal cord injuries. This was the latest of the systematic review in 2020, which was published about 12 studies, 5 RCTs, and 7 observational studies. Again, it does not give any benefit of neurological recovery within, even if given within 8 hours, and the risks are always there. I was very interested in looking at the near hanging. A lot of patients with near hanging, I mean, there would be some discussions about whether to give steroids or not. And I could not find any, but even a case study which actually showed that there was any benefit. Finally, I found this and best bets evidence which they've looked into, and about 577 papers where use of steroids for near hanging showed some benefit, but they did not find any evidence for or against the use of steroids. I mean, although they mention local guidance, I would refrain from using any steroids for near hanging. And the doses of steroids thought about for near hanging are usually very large doses, so they probably will have more effect. However, when we see if the near hanging has occurred, again coming back to spinal cord injury, which is evidenced, then it becomes a bit controversial whether to use it or not. In view of the previous slides, which mention not much benefit, we should probably refrain from using it even at this stage. Okay, so now coming to raise intracranial pressures, there are several reasons why intracranial pressures can be raised, and some of the positive benefits of steroids and the most useful ones would be in the CNS tumors, where as early as 1957, prednisolone was given to 20 adults, and there was some improvement in the neurological function because of reduction in edema in patients with brain mets from primary tumors elsewhere, as well as primary tumors within the brain itself. However, we must, the way in which it probably works is it increases membrane stability, it corrects the sodium, potassium, and water flux across the membranes, and ensures that there is some amount of reduction in the brain edema. We know about the we do know about the vasogenic and the different what is the other one called cytotoxic edema. Most vasogenic cerebral edema forms because of disruption in the blood-brain barrier, but and the cytotoxic edema results because of insult or injury to the neuronal or the endothelial cells within the brain. And if we have peritumor edema, it is mostly due to, I think it's vasogenic edema more than cytotoxic itself. Sorry, it is cytotoxic or cellular edema. And am I correct? It's vasogenic. Can someone correct me? It's vasogenic edema is tumors, and cytotoxic edema is from traumatic brain injury and strokes. Yeah. So there must be some improvement in the function. So steroids are also good during the palliation. They play a role in stabilization for neurosurgeries. And if all other methods of antiemetics have failed in tumor patients, it's a very good antiemetic. It's one of the multimodal mechanisms as an antiemetic. Tumors which cause a disturbance in the hypothalamo-pituitary adrenal axis, it helps in as a replacement therapy. And one other indication is for children with brainstem tumors, pre-radiotherapy, steroids are also used. From brain abscesses, it was interesting to note that most of the recommendations is based upon animal studies, and where in 1976 or on in the rabbits or in rats in 1987, um, it started being recommended. It reduces edema and causes a potential and reduces the potential neurological sequelae in brain abscesses. However, there was uh, a systematic review in which was published in 2018, where dexamethasone administration reduces mortality in patients with brain abscesses, about 500 patients. And however, they did not find uh, in any increase in mortality in these patients. So probably it's like there's no increased mortality, hence it can be used. The doses usually given is around 10 milligrams as a loading, followed by 60 up to 16 milligrams in divided doses until symptoms of the patient because of the abscess gets relieved. So ideally these abscesses needs to have a source control, and once the source control happens and the symptoms reduces, the steroids should be stopped. In the edema due to traumatic brain injuries, the Lancet published in 2004 the effect of intravenous steroids on mortality, and it was a placebo controlled trial, and they did not show any improvement in the mortality in this particular trial as well. And at 2 weeks, at 2 weeks of the injury which is happening. In hemorrhagic stroke, so stroke is other place where steroids are thought about and used quite extensively, but and evidence proves otherwise. The earliest studies which I could find was in 1973, where there was some improvement in quality of life, quality of the survival in these patients only on particular days. However, the overall quality in those days, they did not look at anything more than hospital survival or 28-day mortality. There was no statistical difference in the survival for these patients where dexamethasone was used. In 2005, there was an article published about subarachnoid hemorrhages and primary intracerebral hemorrhages as a review, almost about 250 patients. They're not a single studies, but number of studies put together as a review, and again no beneficial or adverse effects of use of steroids in cerebral. I think this brought in some of these studies did bring in a thing that you can use it. It's not going to cause any adverse effects, but again, one of the latest guidelines for acute treatment of edema in neurocritical patients does not recommend any use of steroids to improve neurological outcome or mortality. In fact, it increases mortality, and complications such as hyperglycemia, infections, and GI bleeds actually increase in people who have been given steroids. In ischemic stroke, again, one of the earliest studies was about in 113 patients, 54 got steroids in 1986, and within 48 of stroke. Interestingly, most of the studies have looked at the early giving steroids in the early period within the first 48 hours. Again, there was no mortality difference in these two groups in 1986. But in 1988, when they did the steroids as a retrospective analysis from more patients, they did find a higher mortality, but some improvement in as well as higher mortality, as well as not so much improvement in their disability scores at the end of the hospital stay of 28 days. So Finally, there was a Cochrane review in 2011, which mentioned that there was no difference in death at the end of 1 year from most of the studies, and even the functional outcome of these survivors at the end of the year did not show any difference. So again, your hemorrhagic or ischemic strokes, I think we should keep away from steroids at all points of time, and so that there is no worsening of mortality. I just went through a couple of other special circumstances. We don't come, these are rare, but we do come across them occasionally. Theoretically, in GBS, it can modulate inflammatory polyneuropathies and reduce complications. However, the study in the Cochrane review in again in 2016 with a quite large number of patients did not show any improvement in the disability grade for these patients. In fact, there was the controls. It favored the controls, as we can see, with respect to steroids and complications. Most of these studies again are prior to 2000s, in the 1970s to the 2000s. However, that's the best evidence we have at this point of time. Probably it's not necessary to do any more studies, is how it's looked at. Some useful things as a ending slide. I mean, most of this is and they are rare in intensive cares, but we do come across them occasionally. So multiple sclerosis, which is a relapsing and a progressive disease, extremely debilitating for the patient when there are flares, and steroids do help. Pulse dose of steroids do help, and these flares are usually seen as vision loss or limb weaknesses and cerebellar dysfunction. And myasthenia gravis, again an autoimmune response against the postsynaptic nicotinic receptors, acetylcholine receptors, and it causes weakness, general fatigability, worsening, and during flares again you use prednisolone up to 1 milligram per kilogram if they come into the intensive care. Bell's palsy, again a sudden weakness in the facial nerve regions where because of inflammation and compression. I mean, if it is traumatic or not, steroids do help, and the prednisolone given 1 milligram per kg and tapered over almost for the next whole week. Actually, I mean, this is a group of evidence for giving steroids for in improving or not improving the neurological outcomes and in relationship to the nerves. I would actually finish the short presentation for today, and we can always have a discussion about any change or difference in practice with anyone. Sharath.
Yeah, thanks, Shashi. That was a great review actually, because we have a lot of centers using steroids for all possible reasons. So we can actually present this as documentary evidence to say that there is no role. Just a few queries like Crash One. When they did it, yeah, the evidence is quite clear that steroids actually increase deaths. So, but the thing is, if you talk to the neurologists or the neurosurgeons as to why they still probably prefer steroids, some of them say that this, especially with the contusions, when there is pericontusional edema, so steroids still tend to have some favorable outcome in those patients as far as decreasing weakness goes. Yeah, it does not get converted to mortality. So that is their bias in probably using steroids. And also, even Crash One probably didn't give us an exact reason why steroids actually caused
No.
such mortality in the group where steroids were used.
No, and that is why they went on to look into the next group of patients. But look, at the end of the day, if you look at a very large group of patients and the complications, which are much more, and the benefits of, there is a higher mortality even if it is at around 2 months or 6 months. So we cannot, it's very hard to accept that the small benefit someone may anecdotally see in these patients who are with
Yeah.
neurology. It's not, it is a feeling more than a reality is what I think.
Yeah.
Oh, it probably helps their functional recovery
Yeah.
in
Yeah.
these TBI
Possible.
patients.
Yeah. Correct. Yeah. Thanks.
Yeah, it's Dilip here. Hi, Sharat. Just to comment on what question you asked, right? It's very similar in say, steroids for ARDS also. Like there are questions that maybe there is some cohort that might improve, but there are three factors. In my view, I think there are three factors here that need to be addressed. One is mortality the appropriate endpoint? Should we be looking at the performance based on like CPC scores, for example, CPC 1 and 2 being poor performance after the event, and 3 and 4 being better performance. So one is mortality versus CPC. The second one that I would look at is, are all brain injuries the same? Just like we say ARDS may be actually 8 different diseases, 2 of which are steroid responsive and 6 are not steroid responsive. Just like you said, if we can identify which is the brain injury subtype that responds to steroids, then we can just say, okay, that a TBI or a stroke, if these things are present on a perfusion MRI, then they may be more amenable or steroid responsive, so to speak. So I think the second point would be identifying patterns that fit a favorable profile and then matching the drug to the actual disease. So maybe TBI or stroke is a large basket, and we need to pick out the inflammatory subtype that actually may respond to steroids. The third factor that I think needs to be clarified in the studies is, if you're going by the CPC criteria to adjust for severity and for the type of injury, then the outcomes and the dose mapping need to be tailored. So basically, what I'm saying is, okay, maybe the neurosurgeons are right that some cases may need it, but right now we don't know which subtype fits what with regard to the outcomes and the type of brain injury, because for sure not all brain injury has the same outcomes when you are giving steroids, because they are probably different diseases. So I don't know if that story is done yet, and until then I think we should at least do no harm and maybe then search for possible benefit, because we have this lesson from ARDS, so perhaps some value in looking at that data.
Yeah, yeah, agree. Like I was pointing to the exact thing because, like they say, especially with this multiple contusions or say where there is MRI evidence of pericontusional edema, only those subset of patients probably tend to have some neurological benefit. Yeah, might be that actually eventually doesn't convert to a mortality difference. That might also be true.
I mean, one other thing is, I mean, by the time a TBI, a severe TBI patient gets an MRI done, if it is done, uh, uh, if it is done very early, or and at what stage it is done, and would there really be a huge change in this in their functional outcomes because of that is always a question mark. And and Dilip, with the way it is true that theoretically there may be subsets which you can actually tease out, but teasing out these on a practical sense is almost an impossible task to do, apart from a research part. Do
Yeah,
you?
but I mean, fundamental question, Shashi, what is the evidence that steroid actually reduces any kind of edema? Forget brain. Does steroid actually reduce edema?
It just modifies your membrane stability to a certain extent. It doesn't remove the fluid from the places where it's not supposed to be there as
Right.
such
So
directly.
we don't know if steroid, it suppresses inflammation, maybe that
Mhm.
is fine, but we don't have evidence that it actually removes edema per se, right?
No, it does
Okay.
not.
Yeah, that's so. That remains the question remains then. Like in the brain, if your primary concern is edema, then is that even the right agent? Because
Yeah,
inflammation may happen, by other means, right?
yeah,
So
yeah.
yeah, Sanat, sorry, you want.
Sanath?
In airway, definitely steroids are proven to reduce edema in airway.
Yeah, in airway, especially
Oh,
upper
okay.
airway, Yeah, I agree, but not all tissues are the same, right? We know that steroids can cause harm in viral myocarditis. There's an increased incidence of worsening of viral myocarditis if you give steroids, irrespective of the edema. We don't know that part. So the harm potential is what I was concerned about.
Sandeep?
Yeah, actually, even just not the reduction or not reduction, it's how much time does the steroid take, like hydrocortisone or dexamethasone, whichever you use. They take around 6 to 8 hours or 12 hours probably to act on the reducing the inflammation part and then reducing the edema if we think even they reduce. Even the airway is also included in that. So what immediate effect we want, I'm not sure how much it is going to give, even if it reduces. One point I wanted to add.
Mm. I think if you look at immediately acting drug, even dexamethasone, which immediately and it acts for a longer period, I mean, that is why even in cerebral edemas, because of tumors, there is some amount of benefit. I mean, someone who has had a seizure because of a tumor metastasis, it is started as early as possible. So, but again, coming back to other reasons how the edema is developed, the inflammatory process reduction is whether steroids actually act on that is still not very clear. And in TBI, etc., we don't even know the all the processes by which the edema actually occurs, apart from the presence of blood in the wrong place. Monica?
Shashi, this is just, it's not a very deep question, not a difficult question. I just want to know the duration of steroid treatment which is recommended for tubercular versus non-tubercular meningitis as per the guidelines.
So for tubercular meningitis, it is recommended up to 8 weeks, and for non-tubercular meningitis, only for 4 days.
Okay, okay, all right.
Up to a maximum of 8 weeks in TB meningitis.
Okay. And TB meningitis, there is evidence for outcome, just like we
Yeah.
have.
Yes, with and without HIV, there is evidence for improved neurological outcome in TB meningitis. Very large doses are given in TB. So normally in bacterial meningitis, you give about 10 milligrams of steroids as a loading dose, and followed by 16 milligrams in divided doses. In TB meningitis, you give the same thing IV for 1 whole week, the same dose, that is around 16 milligrams per day, for 2 weeks, followed by reduced doses like 0.3 to 0.4, then 0.2 milligrams per kilogram for the next 1 week, and then reduce it, and taper it down for the next at the end of 8 weeks. So first 3 weeks you give large doses.
Okay, all right. Okay, thanks.
Sandesh?
Yeah, a quick comment about vasogenic and cytotoxic edema, which you mentioned. So, vasogenic edema is when the blood-brain barrier is disrupted, and cytotoxic edema is when the blood-brain barrier remains intact. And actually, there is even we can make out this difference in MRI as well. So, in MRI, cytotoxic edema will show diffusion restriction, whereas vasogenic edema will not show diffusion restriction. So the pathology also will be very different, and that's one of the reasons why steroids won't act in cytotoxic edema. It may work in vasogenic edema, but it won't work in cytotoxic edema. And Shashi, I may have missed this. Did you speak about touch upon the role of steroids in strokes?
Yes, both in hemorrhagic and in ischemic strokes, there is no role of steroids as a single liner.
Yeah, thanks. That's all.
Yeah, Rolly,
sorry.
Yes, so regarding TBM, I just wanted to confirm, is it 4 weeks? What I had read was that we weekly taper. Is it 4 or is it 8 weeks? Just
So
wanted to confirm on that.
first 2 weeks you give the large dose, then the next 2 weeks you give a smaller dose, and then you start reducing is what up to test is.
Okay, right.
I can reconfirm in a minute.
Yeah, I have. This is from Sanford that I was following. That it was like 0.4 milligram per kg per day for the first week, when we started off. Then we reduced it to zero point 0.3 milligram per kg second week. Then zero point 0.2 milligram per kg third, and zero point 0.1 milligram per kg fourth week, and then stop. This is what
Right.
I have been following for TBM. Like from Sanford, I have to check in it up to date.
I'll just relook at up to date. Okay, for patients more than 14 years, dexamethasone 0.3 to 0.4 milligrams per kg intravenously for 2 weeks, then 0.2 milligrams per kg per day on week 3, then 0.1 milligram per kg on week 4, then 4 milligrams per kg per day orally and taper 1 milligram each week. Total duration approximately 8 weeks. In patients less than 14 years, it's 0.6 milligrams per kg for 4 weeks, reducing course over 4 weeks, up to 4 to 6 weeks in total.
Right, sir. Right. Thank you. Thank you, sir.
Actually, the exact same thing which we were discussing. There is I just found this. There is a study called Dexcon TBI trial which is started in 2020 and probably will complete by 2024. Like for are steroids beneficial for like the vasogenic pericontusional edema? Probably they've enrolled subjects. So got to see what
So
the
it's
outcomes would be.
a Dexcon study.
Yeah, Dexcon TBI.
Okay, I'll see. This
TBI,
was
huh? So not in strokes, but in TBI.
TBI, yeah. And it's very specific. Like it's dexamethasone for the treatment of vasogenic pericontusional edema.
So they are doing an MRI screening,
Uh, what is this?
like in terms of selection criteria, they would have to, right?
Yeah, yeah, yeah. They mentioned CT in the literature. I don't know what they're doing MRI.
Because CT will not be able to tell you.
Differentiate cytotoxic and vasogenic. Yeah.
Okay.
All TBA will be vasogenic only, no?
Yeah, but I mean, if they're trying to differentiate the type of responders versus non-responders on an imaging pattern, it might be useful.
Yeah, yeah, yeah.
But they've given the primary outcome is GCS perform 1 month after 6 months and 6 months after the TBI. Secondary outcomes is neurological deterioration with TBI. Volume of so there is a volume of pericontusional edema before and after 12 days of treatment, and neuropsychological tests at 1 month and 6 months after TBI. Intention to treatment analysis.
So they're looking at functional outcomes also.
They're
not-
looking at functional outcomes. Yes.
Yeah, good. Okay. I think Vibi had a question and Kiran has also posted one. Vibi, you have a question?
No, it was, sorry, that's a mistake.
No problem.
Steroids in intracranial tumor resection. Yes, I think steroids are, I mean, the two biggest take homes is in meningitis and strep pneumonia meningitis, to a certain extent in and tuberculosis meningitis, definitely a certain extent in back in abscesses, and the last thing is tumors, apart from rare conditions such as myasthenia gravis, etc. So tumor resection for stabilization preoperatively as well as postoperatively, post resection. Post resection, I have not looked into the evidence as such. It is useful. It is useful, and it's got many other uses apart from the tumor and its edema only. Great. Okay, so
Just to, oh, sorry, one more thing.
sorry, Dilip.
I was looking at the steroids and, the effects. See, if we are concerned about vasculature and edema, there have been animal experiments on injecting intra-arterial steroids in the brain for like strokes and for brain injury, just to see the effect on the edema. So, I mean, there is literature that there is direct toxicity and reduction in edema. So people have tried all kinds of things to look at it, and I don't know when it will come to humans. But if you're looking at a risk reduction in just edema alone, that would be a very aggressive test or study to do if that's what you want to. Maybe like a study where you are giving intra-arterial TPA anyway as part of a thrombectomy protocol, and you want to test it, you might combine the two. Just throwing it out there because that has been done before in non-human subjects.
Yeah. Okay. Recently, or has it been very old?
No, these are old studies.
Old studies.
I have a question. This is Varna, if there is time.
Yes. Yeah,
Okay. Recently, I had a patient, I wouldn't take much of time, a young girl who presented with severe headache for almost 2 months to an extent that she stopped working. And subsequently, she went and she went to a couple of places, and someone recommended MRI brain. MRI brain did show that, the report, I would just say the report, benign intracranial hypertension. That was I think the intensivists have been part of the management as well, but not this treatment, what I'm going to say, is not theirs. So benign intracranial hypertension. And then subsequently, neurologist has seen and started her on 4 milligram TID of dexamethasone and acetazolamide 250 milligram TID, 500 milligram TID. So this was the dose prescribed. Then she came to ICU because she had severe pain and severe headache. And when we looked at the blood pressure throughout, there was no mention about blood pressure. When we checked the blood pressure, her blood pressure was 220, 110, and it was crossing over 200s. Then blood test starts, her creatinine was 7. And if I go to MRI findings, and urea of around 2, I think it was around 130, 140. She's a young girl, or I think around 28, 29-year-old girl. Subsequently, her history taking tells that she's been taking non-steroidals for back pain for almost 6 months. And it looks like a couple of times her GP had checked her blood pressure, which was around 150, 160. And he said, you're putting on weight, you should cut down on salt and all those things. So I was just wondering, I know it's clearly, after we got to know the creatinine and all those papilledema, then we got ophthalmologist to have a look. There was clearly type 4 retinopathy with papilledema. And she had, in fact, gaze palsy. It was more than nerve palsy. It was essentially gaze palsy, where they started complaining it's squint. She's developing squint. So I think first thing, of course, I did was stopped steroids and then weaned off acetazolamide. So here, benign intracranial hypertension. I think what is disappointing is at no stage hypertension was taken into consideration. Is there any role for steroids if it's isolated benign intracranial hypertension?
I'm not sure, but I'm just looking it in, and I'm not finding.
It's not a first line, and it's pretty like last line to be used in benign intracranial hypertension. It also causes rebound. Ideally, it's not part of the standard treatment profile. The interesting thing is the gaze palsy could be a false localizing sign that's known to happen in raised ICP.
Agree, completely agree. I was asked to do lumbar puncture, but I was reluctant because it's not going to change the management. And she came yesterday for follow-up. Her creatine's gone into chronic kidney disease. Her CMD is completely lost, but creatinine had settled to 5.8. Settling. I think it's going to come down a bit further. And we are not going to do anyhow kidney biopsy for her. Lupus, ANA, mildly positive, but irrespective, she's not behaving like someone who's got lupus. and I'm not pushing myself for kidney biopsy for her.
Can it just mentions in terms of steroids itself, in a setting of acute visual loss, there is some evidence to give glucocorticoids as a temporizing measure in fulminant intracranial hypertensions, because she was symptomatic, and that may be the reason.
Oh,
But
sure.
it's a if the large dose methylprednisolone, 250 milligrams 4 times a day and then taper it down along with acetazolamide.
Okay.
That's a
Okay,
therapeutic dose, right? I mean, that's a pretty high dose.
It's very high dose, but it's an urgent temporizing measure only if there is an acute visual loss because of intracranial hypertension.
Sure. Okay.
Okay, thanks.
Thank you.
Thank you.
Great. Well, thank you, everyone. It was a good discussion and some learning.
Thank you, Shashi. Thanks.
Thanks.
Thank you.